This is Dr. Mohammed Samji from the University of Manitoba, presenting on behalf of myself and Dr. Anthony Kaufman our chapter on radiosurgery for functional disorders, to be published in Yeoman and Wynn's Neurological Surgery. Firstly, we will present a background on the use of stereotactic radiosurgery for brain lesioning. Next, we will present the application of stereotactic radiosurgery in the field of craniofacial neuralgias, followed by movement disorders, and finally psychiatric disorders. Stereotactic frame-based platforms for the delivery of ionizing radiation can be used to create lesions anywhere in the brain with a minimum diameter of 4 millimeters. The delay to onset of treatment effect corresponds well to animal studies as well as clinically observed effects and ranges between 2 to 3 weeks. Compared to other functional neurosurgery modalities such as deep brain stimulation and focused ultrasound, the relative advantages include a high degree of accuracy, non-invasive mode of delivery, a single treatment session, and targeting of deep brain structures. The disadvantages include the irreversibility of lesions, as well as uncommon radiation-related adverse effects. Craniofacial neuralgias include trigeminal neuralgia, glossopharyngeal neuralgia, and sphenopalatine neuralgia. Radiosurgery is an option for the treatment of all of these syndromes. Trigeminal neuralgia, in its classical form, is characterized by brief, lancinating attacks of pain affecting a unilateral trigeminal distribution. A typical management algorithm for trigeminal neuralgia is characterized by 1. The provision of medication such as carbamazepine. In the event of failure, second-line medical agents can be provided. When side effects prove intolerable or medications are no longer efficacious, patients move on to 2. Microvascular decompression. In patients whom microvascular decompression is ineffective or who are not surgical candidates, a variety of third-tier options exist. These include microsurgical trigeminal rhizotomy, glycerol rhizotomy, radiofrequency rhizotomy, or gamma knife radiosurgery. For patients treated with gamma knife radiosurgery, a significant improvement in pain levels can be seen in approximately 85% of patients. Latency of pain relief is usually 3 weeks, and significant recurrences typically occur at a median of 2 to 5 years. MS-related trigeminal neuralgia represents a special subset of trigeminal neuralgia in which the etiological agent is typically not the presence of neurovascular compression. For these patients, lesioning procedures can be considered earlier in the disease course. Here, a demonstrative planning scheme for gamma knife radiosurgery is shown for trigeminal neuralgia. Trigeminal neuralgia is most commonly treated with a 4 mm collimator shot centered 2 to 4 millimeters anterior to the nerve entry to the pons on the symptomatic side. The prescribed dose is usually 80 grays with the 20% isodose line just encroaching on the brainstem surface. Here, we demonstrate that the trigeminal nerve root may be well visualized with CT cysternography after injection of radiodense contrast material through a lumbar puncture. This can be performed if MRI is contraindicated. Tumor-related trigeminal neuropathy is another special subset of trigeminal pain conditions. It is notable that patients with pain due to benign tumors of the cerebellopontine angle frequently achieve pain relief when treated with stereotactic radiosurgery. Nevertheless, patients with severe and immediate pain may be better candidates for surgical decompression. Glossopharyngeal neuralgia is a craniofacial neuralgia that is highly analogous to trigeminal neuralgia. It is first treated with medical therapy, followed by MVD, and in the event of failure, stereotactic radiosurgery is an attractive therapeutic option. Movement disorders represent a growing field for stereotactic radiosurgery, with tremor being at the forefront. Tremor may be classified as essential tremor, Parkinson's-related tremor, and MS-related tremor. From a radiosurgical perspective, the target conventionally chosen for tremor is the VIM of the thalamus contralateral to the more symptomatic side. The efficacy of radiosurgery for tremor is quite high, with close to 90% of patients experiencing improvement in tremor. Furthermore, the safety profile for radiosurgery is quite favorable, with complications being very rare. Here, a demonstrative planning scheme for gamma knife radiosurgery lesioning of the VIM for tremor is demonstrated. There are a variety of therapeutic options to be considered for medically refractory tremor, including deep brain stimulation, stereotactic radiosurgery, and focused ultrasound. While a head-to-head trial has not been performed, the observational data seem to suggest the results of radiosurgery are at least as good as that of deep brain stimulation, which has classically been considered the second-tier option for medically refractory tremor. Finally, radiosurgery has demonstrated some positive results in the setting of severe OCD. The typical target is the ventral portion of the anterior limb of the internal capsule. Bilateral cingulate gyrus lesions have also been performed. A lesioning procedure for severe disabling OCD can be considered in appropriate cases.